Director ejecutivo de HACER, para conversar con ustedes y con un invitado muy especial desde nuestras oficinas aquí en Saint Paul, Minnesota, como siempre, y para hablar de un tema muy importante que en realidad poca gente lo estamos eh, viendo en su entera dimensión de nueva cuenta y por lo tanto es sumamente importante hacerlo. Les aviso que en esta ocasión la conversación será en inglés con nuestro invitado de hoy, Adi Chandrasekhar, que es el director médico, Medical Director de Primary Health, quien está además sumamente informado. Esta conversación será grabada y estará disponible para ustedes vía nuestro canal de YouTube con subtítulos en español, si quieren pasar la voz, pero repito, va a estar completamente en inglés este día y yo sé que muchos de ustedes son bilingües, así es de que siéntanse libres de conectarse con nosotros. Nos acompaña también Satkiel Molina, nuestro manager de comunicación, y él nos estará haciendo llegar sus preguntas, como siempre, así es de que por favor, si tienen alguna duda, postenla y Satkiel nos las hará llegar. So, uh, again, welcome everyone. We are here at HACER again in our info HACER, just this time to tackle down again one of the issues related to COVID-19 that, well, is still some sort of unknown what is happening, is unknown what is going to happen after the crisis period is being decreed like there is not anymore. However, today we are going to be talking about what is going on for real and what we should do. And today we have a special guest here with us is the medical director of primary health, Adi Chandrasekhar, who is really an expert, and it's a real pleasure to having him talking to us about these events. He also leads a very wonderful organization. You can see he's proud of it with his shirt showing us primary health in the chest. And we are really pleased to work with them in a couple of levels of interaction. But also primary health is one of the vaccine providers for Minnesota, not less for COVID-19. And thank you so much, Adi. So if you can introduce yourself to the audience and tell us a little bit more about you.
Thank you, Rodolfo. That was very helpful, and thanks so much for having me here. So my name is Adi Chandrasekhar. Like Rodolfo mentioned, I am the medical director at Primary Health. I'm also a practicing physician. I have seen patients for 10 years now as a primary care doctor. I still work part-time in a primary care clinic, a community health center actually in the Boston area where I'm based. And I'm very passionate about public health, and I'm looking forward to this conversation that we're about to have around COVID vaccines.
Thank you so much, Adi. A real pleasure. So we were living like the last 3 years in some sort of uncertainty about COVID. And all of a sudden, like we all received the communication that the crisis was over. But still, we need, as a community-based organization, we need to deal with promoting people continue vaccinating themselves because COVID is still with us. And we know now that COVID might not be going anywhere anytime soon. And also, we see recently that the data that it's being reported shows that the number of cases going down drastically to the point in which almost 1% of the population is showing or being diagnosed with COVID. But at the same time, we see a very kind of rapid increase in the number of hospitalizations because of COVID. So around even 9% last month of the people who was hospitalized, it was because of COVID consequences. What can you tell people about this? Because we see that discrepancy between number of cases reported and number of cases that are in hospital because of COVID.
Yeah, that's a great question. So I think what we need to keep in mind here is, 3 years ago when the pandemic first started, our ability to get testing was quite limited. Our ability to get testing was often limited to going in and getting a nose swab, the PCR test. And it was very easy to report on that as a mass level because you were getting the test through a provider and they would report it to the state. And then you could see very accurate numbers of how many people actually have COVID, or close to accurate numbers, I should say. What happened as the pandemic evolved was the availability of rapid tests that could be done at home, as I'm sure most of us at some point have swabbed our own noses in our house to do, which is great because it definitely makes it a lot easier to get that test. However, that also means we don't report them to the same level of accuracy, because I could run a COVID test at home, get a positive result. That's good for me to know. But I don't then have the ability to report that out to the state. And so the numbers of active COVID or new COVID diagnoses that we see might not be truly reflecting the COVID burden right now, because a lot of people have switched away from going into a hospital or clinic to get a swab and are just getting it at home, which again is a good thing. But that does sort of artificially lower the numbers that we're seeing publicly reported. Hospitalizations, on the other hand, are easier to capture because obviously, again, they still get reported out in a more structured way. So that would explain some of the discrepancy that we're seeing. The other thing we should also keep in mind is 3 years into the pandemic, a large portion of the population has either already had COVID or been vaccinated against COVID, or both. And we know that causes us to build immunity over time, so it hopefully protects us better. What's interesting is who is ending up in the hospital even at these times, right? So we see a very disproportionate number of people ending up in the hospital who are either unvaccinated or under-vaccinated, meaning they started out but never completed or never got a booster. And it particularly affects the elderly, for instance, in a very disproportionate number.
That is completely true. I was looking at the statistics, and 65 and older people are the ones who are coming more, say, with more numbers to the hospitals because of COVID. But almost 99% of them have not been vaccinated. So in this particular situation, vaccine is kind of a key. And we're going to come back to the vaccine. But first, before going there, something that we've been asked all this time is, what is the difference between COVID-19 in March 2020 and COVID-19 at the end of the 2023? We know that there are variances and there are also different lineages. Can you tell us a little bit about that? What are the differences between what we learned about at the beginning and what it is happening now?
Yes. As with many viruses, the flu being a good example, the COVID virus is not static. It keeps changing and evolving over time. We develop ways to try to avoid infection by our immune systems being trained to recognizing COVID virus. And the virus is also learning how to fool our immune systems by going ahead. And so the big difference between 2020 and now is when it started in 2020, it was an unknown entity. We didn't know what it was, how it would behave. We had no vaccine against it. And so it was a very different situation, obviously, than now. Over time, what happens is the virus naturally mutates. And so it creates various combinations of genes that produce different effects. It would so happen that some of these mutants have the ability to evade immunity that is generated by the vaccine, and then those ones become the dominant strain of the virus going forward. And this is a constant process. This is not static. People heard about new variants. Initially, they were alphabetical. You had the Delta and the Omicron, and now there are even more complicated, longer names because we're going to constantly see this. And we know this from influenza. We've seen it in influenza, where every year we get slightly different variations of the influenza virus from the past year. And it's a very similar process. So I think we should be comfortable with the idea that this virus will constantly keep changing a little bit as we go forward, because that's just what it does.
Right. And that is also something that comes to us in a way of a question. Is related to the number of cases by ethnic or racial groups. We notice at least in Minnesota data, that the American Indian communities are by large more affected by COVID. I know that the way they are identifying this is through the sewer, but I wanted to ask you about that also. But also, like Latinos, for example, or Hispanic communities are to the level of white and even multiracial communities. But yeah, and the largest numbers are coming from American Indians, and then Black and African American, and finally they are being more affected. How can you establish some relationship between the variances and the number of cases by race and ethnicity? And if it is not, how can you explain that to the community?
So it has been true, I think, pretty much throughout the pandemic that we've seen that there are huge differences based on race and ethnicity in terms of who is getting sicker with COVID. Some of that, researchers might try to explain on account of biological differences and whatnot, but the reality is the vast majority of it is not necessarily that. It's really more structural. The communities of color in this country live in settings where COVID transmission is easier often, and this is because they're more likely to live in a crowded home. They're more likely to live in intergenerational homes where you have a grandmother and a little kid living under the same roof, and these factors make it easier to transmit. We also know that there has been higher rates of vaccine hesitancy amongst people of color, which in turn means, again, there's fewer people there that are immune from that as a result of the vaccine.
Right.
So there are different reasons why that happens. And of course, it's not unique to COVID. I think we can see that in so many diseases, both infectious and not infectious. So some of it is explained, or I should say a large portion of it is explained by socioeconomic structural changes that often exist between racial and ethnic groups. We should be careful about not labeling everything as simply being linked to the race or the ethnicity, because in a perfect world, if we had everyone living in the exact same circumstance, we may not see that.
That is really important, and I want to really underline that and stress the point and don't try to establish that correlation, because it's more related to socioeconomic conditions of living, or those socioeconomic factors that affect health. It's not only bringing more COVID cases, but also some other illnesses are there in the same kind of distribution. So that is really important. But another indicator that it's there is the age. So what are the probabilities of having or acquiring the virus according to age? Is lower by age, or if you are younger, or it is higher if you
So
are older?
the
Still?
risk of getting the virus, there's two things. There's risk of getting infected with the virus and the risk of getting sicker when you get infected with the virus. At this point, obviously, some communities are more likely, some age groups are more likely to see that. For instance, the youngest age groups, we have our children in settings like daycares and settings like schools, typically much easier to pass infection from one person to the other. We know that because, every year, even before COVID, we've seen outbreaks of so many respiratory infections in these settings. Same way at the other end of the age spectrum, we have a lot of our elders who again live in congregate settings, which means they may live in a nursing home, an assisted living facility, or some facility where there's lots of senior citizens sort of congregating. So it's not that the likelihood of your getting infected is different by age as much as what setting you're in. What is also important is who gets sicker from COVID-19. At least at present, it's very clear that there's a very disproportionate impact by age. So the older you are, particularly 65 and older, your risk of getting sicker from COVID-19, needing a hospital stay or something like that, is much higher as opposed to children, for example. Most children, even though they get COVID-19, will be much less likely to land up in a hospital from that.
So the severity of the illness is also correlated with age by nature.
That's correct. That's correct. The one caveat, of course, being the very, very youngest. I mean, if you're talking about newborns, in particular newborns that might have other health conditions, that's a different situation. But as a general rule, it's really right now the elderly who are really landing up in our hospitals disproportionately.
Yeah. And you mentioned something really important here is like the exposition for kids and people in general is different depending on the settings you are interacting with other people. But also you mentioned some aspects of the seasonal illnesses, so like the flu, like the RSV. Is COVID going to be seasonal too, or it is already?
It certainly seems to be settling into a pattern of seasonality, much like with RSV or the flu, where typically those viruses, those respiratory illnesses, are more common in the colder months. But we didn't see that pattern very clearly at the very start of COVID-19. But right now, it certainly seems like that's what is going to happen. So in many ways, it will sort of become similar to flu in that sense, in that we might see numbers peak in the winter. That, just as with the flu, as I always tell, that does not mean the rest of the year there's no COVID-19 or no flu. They're all still there. People still get sick from them, even outside of that period. It's just that the number of cases cluster in that period.
Perfect. And again, just please pay attention to that. This flu is all year round, but the number of cases are picking up by the winter season. So, and to prevent the serious effects of that, vaccination is kind of the main formula. And we do know that by October, November, you can take measures and prevent the flu with the vaccine. What is going to happen with the COVID? When do we have to take the vaccine? At the same time as flu? And is going to be effective 1 year, or what is going to happen?
It certainly would be very similar. So this year we saw the new booster for COVID came out in the fall, just similar to when the flu vaccine usually comes out for the season. So if the seasonality is that the cases peak in the winter, typically the vaccine becomes available sometime in the fall so that people start taking it at that point. It certainly appears that it might end up being a year-on-year sort of vaccine similar to the flu again. And that's largely because, just like with the flu, the virus is constantly changing a little by little. So each year when you get the vaccine for flu, your flu vaccine is a little bit different than last year's vaccine because the scientists are trying to predict how the virus will change. And so COVID-19 will see similar patterns over time. So I do expect that it will become something where, just like you go in the winter to get your flu shot, you probably will also get your COVID shot around the same time.
And just to insist that according to data, if you are unvaccinated, it is more probably that you have serious effects of the COVID whenever you acquired it. And it is really important. But let's talk about the vaccine, because you might remember when the vaccines came out, it was kind of a lot of talking on the way that first, how fast it came out, then what might be the components of it. So at the beginning, we needed to have a shot, then it came the booster, and then it came the bivalent vaccine. Today, we have a new vaccine. Can you tell us how the process took place and what are the differences between those vaccines?
So the very first COVID vaccine that came out, this was in the winter of 2020 that it first started coming out. It was close to December by the time it came out, which was based on what virus was circulating some months prior to that. So the very first strains of the COVID virus that were circulating that summer, they picked those to study, and that was the first vaccine. The subsequent booster that you got was actually the same vaccine. It didn't reformulate. It was the same vaccine. They were just giving you an extra dose to try to get your immune system peaking up again. The bivalent booster was the first vaccine that was actually different than the first initial vaccine. The bivalent booster used a different combination of the COVID virus strains, depending on what was starting to circulate later at that stage. Similarly, this year's vaccine that just came out in the fall is based on what we think were the most recent strains of virus that were circulating. So the first vaccine and those initial boosters that you were getting were basically the same vaccine. They were not any different. They were just additional doses for your immune system to learn. But since then, what you've seen coming out are basically boosters that target newer variants of the virus.
Perfect. So the new one kind of happens to be more effective than the previous ones. Would you say that?
So what is true is that because the newer vaccine is targeting the more recent strains of the virus, it would be more effective against viruses that are circulating closer to that time. Now, there's always a game of catch-up that we're trying to do, right? So, for instance, we know that even in the period that since when the current COVID vaccine, the strains that it covers, even in the period since those strains were circulating, newer strains have come about. And that's normal. That's going to keep happening. And so every year we will be sort of teaching our bodies a little by little to move forward. At this point, for instance, if you took that original COVID vaccine, the one that came out in 2020, it's no longer even available. It's not like you can get it, but it wouldn't do much at all because the strains have evolved too much since that point.
Right.
So that's going to be a constant process that we have to get used to.
Excellent. And to that point also, so many people have been coming to our events and saying, I don't want to take the vaccine, just want the flu shot because I know about the flu, but less about the COVID. And the government is telling me that I can acquire the immunity, at least temporarily, if I get sick. What can you tell that people? Because they feel that I expose myself, I just get contaminated with COVID, then I'm going to have the same effect as the vaccine without the pain, without anything else up front. So what can you tell those people? Because we try to convince them to take the vaccine.
So it is true that if you get a COVID infection, your body builds immunity, and that immunity does protect you going forward, right? So that part is true. That's not false. I think where people often get that wrong is not all of us can afford to take the risk of getting a COVID infection to find out if that's the best way to get immunity, right? Many of us might be relatively healthy, maybe younger, and so we get a COVID virus infection, we feel bad for a couple of days, we recover, we feel like what's a big deal. But we have to remember that for people that are at higher risk, particularly the elderly, particularly those with certain health conditions, you could get quite sick from getting the COVID infection itself. So it is true that COVID infection does provide you with some immunity, but particularly for those who are at high risk, that should not be your primary way of getting the immunity because you don't know whether you're going to get sicker or not in that setting, and you wouldn't want to risk that. So I think we must recognize that, for some people that are saying that I would rather get COVID and get immunity by that, if you're someone that's at low risk, that may be fine for you, but it's not something which is true for everyone.
That's true. So you better don't take the risk. Maybe you are going to be making it good, but eventually
And I think that's an important point, right, Rodolfo, which is that each of us has a different risk tolerance. What may seem like a big risk to me may not seem like a big risk to you.
Right.
Um, and 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 that's normal. I think what's important is I want you, if you're the patient, to make an informed decision on what you're doing. I'm not saying you should get the vaccine or you should not get the vaccine, but get all the right information and then decide what you want to do, because I cannot be the one deciding how much risk you want to take for your own health. And that's true for anything in your health, vaccine or otherwise.
Right. And that's why we are here. We are trying to inform people with the right information because, yeah, and that is going to take me to the next segment because first and foremost, we know that at the beginning, a lot of options came up in the United States with the Johnson & Johnson vaccine and then the Pfizer and the Moderna. And all of a sudden, the Johnson & Johnson is not available anymore. And some others are coming in, like recently the Novavax, yeah. And so people are asking us, why is that happening? What makes the government to decide like JJ is not working, but the Novavax is working? What it is there under control? Many people don't know about the FDA and the CDC, like making these studies and validating the effectiveness of any vaccine. But can you tell, like in more simple terms, people about this?
Yes, so you're right. The Johnson & Johnson vaccine, which was available early in the course of the pandemic, is no longer available. We do have a new vaccine, which is Novavax, which got approved this year. The two original manufacturers, Pfizer and Moderna, those are still available from the start to now. I think it's understandable to have a concern when you have a vaccine that gets approved and developed that quickly. I think what we should remember is that doesn't necessarily mean that there weren't studies. These are all still based on studies. Even in 2020, when the initial vaccine was approved in response to the virus, they were studied. They were given to people. You go through a trial. So some people get the vaccine, some people don't get the vaccine. And you see how many of them go on to develop the infection. So that gives you the numbers. So even in that initial approval, while yes, it was certainly expedited, it wasn't that there was no data to show that the vaccine worked. New vaccines are constantly developed in any field, and so that is not unusual. And then as we get new vaccines, we are always studying to see how does this compare to a previous version. If a previous version seems like it's no longer working, we usually phase those out, and the FDA will put a new one in. I think what is exciting for a lot of people is, and we may have a question about this later, but just to go into it a step ahead, which is the initial vaccines, so Pfizer, Moderna, which are still available, are what are called mRNA vaccines. The Novavax, which is the most recent one, is a protein subunit vaccine. That's what it's called. So they're actually different in terms of how they generate immunity for you. The mRNA vaccines, they were the first ever mRNA vaccines to be approved. There was no mRNA vaccine available at that time. It was a technology which was already being worked on, but no vaccine had been developed of that yet. That made a lot of people suspicious, right? They said, I want to be careful. I don't want to put this new thing in my body that I don't know what's going to happen if I do that. Of course, getting that vaccine turned out to be just fine. People did fine with it. We developed immunity. We were able to move ahead with our lives thanks to that. But if you happen to be a patient or happen to talk to a patient who still harbors some of that initial apprehension about this new technology, you can tell them Novavax is completely different. The protein subunit vaccine, that type of vaccines have been around for a very, very long time. That's not new technology in that sense. So if you're someone that says, I'm afraid of mRNA vaccines because they're very new, although at this point, they've been around for 3 years, but if you still feel apprehensive about them, the Novavax vaccine does not have mRNA. It's based in a completely different way, and it also works. So I think it's exciting for people to have that choice if they so feel strongly that I don't want to, I'm open to a vaccine, but I don't really want to try this mRNA technology, but I will reiterate, has been just fine. We've all taken it, and it works just fine, and people are doing okay. But if you're apprehensive, you now have another choice.
Well, to that point, I'm not gonna step up a little bit out of my bullet points here. It's like, say, as a provider for vaccines, and we as organization for vaccination events, we are going to request a number of vaccines available for an event, but eventually we're going to have certain percentage of people who are not going to want the MNR vaccine. How can we talk about having the Novavax available at our events from you or from any other provider?
So Novavax is already available, and so you can certainly order the Novavax vaccine if that is something you want to have in your mix. My advice would be, obviously, you want to look at the demand. You never know how the demand is. I remember initially when we had the 2 mRNA vaccines and the Johnson & Johnson vaccine, the demands were not equal for all of them,
Yeah.
right? Some people really like the idea of the 1-dose Johnson & Johnson. I don't want to come back again. And others said, oh, I don't want that. I want the one that's the latest technology, right? So, and that varies obviously from one community to another. But I would definitely encourage that have the Novavax available, at least as an option to start with, and see how your communities have uptake. Do they have a particularly increased uptake for one or the other? And we can always sort of project forward from there.
Okay, that is good to know. I'm going to be taking notes for the next events because, yeah, some people have been asking us about that. And that is based on what they are learning about the potential risks of having the vaccines, because so many people are talking about, as it was with the GA vaccine, the thrombosis with thrombocytopenia. They are saying that now the new vaccine is causing clots on different kind of ways, like legs or arms or everywhere around. What can you tell that people? Because I was reading some articles. There is no clear evidence, perhaps some coincidence, but how can you convince people that that is not really happening?
So what I would say is, whenever a new vaccine, new medicine, something comes out, we don't know every side effect about it right at the start. But as we go forward, there are surveillance systems for what is going on, and so new side effects might come to light. I know we just spoke of the 3 original vaccines, the Pfizer, the Moderna, the J&J back then, but the reality is, in the world, there are many other vaccines. In fact, a lot of people out in developing countries did not get the Pfizer or the Moderna. They got AstraZeneca vaccine. There are also vaccines that were developed in China that were used extensively in that part of the world. So I think it's important to say that there have been different vaccines right from the start and using very different technologies. Some of them did have an increased risk of causing blood clots. Now, a lot of the studies, at least in those vaccines that had some incidence of blood clots over time, what you need to think about is, remember, getting COVID-19 itself can also increase your risk of having blood clots. And so you have to consider, what is the risk of that happening if you got COVID-19 as well? Don't just think about, if I get the vaccine, what is the risk of getting clot, but also what is the risk of getting clot if I get COVID-19? Because you'll probably see the risk is higher with actually getting sick as opposed to the vaccine. In general, the mRNA vaccines, so the Pfizer and the Moderna, they've not had a particularly high risk for clots compared to some of the other vaccines. So you have options, is what I would say. It is true that we don't have all the data just yet. Some of that will keep coming forward. And again, what's important is talk to your provider at the time you are getting your vaccine to find out what is the most up-to-date information that's available, and make a decision based on that.
That is excellent, and also a very nice segue to the next question, because several of our constituents, the people who are working with us or we are working with, they are coming from different countries. And so many of them are coming and going. They visit or we visit our relatives in Mexico, in Ecuador, in Colombia, even some in Spain. I just want to raise here an anecdote from one friend of us that she was traveling to Spain and she decided to have the AstraZeneca because she said that the AstraZeneca was taking care of the variants that it is there in Spain, and that she was not feeling prepared carrying just the Pfizer she had. So how is that? How much is that true, and what can you tell about that? Is that like the variants are different?
The variants are constantly evolving and changing, right? And the most updated vaccines, all three of them that are currently available here, so the Pfizer, the Moderna, this year's version, and the Novavax, they're all targeting the most recent strains. So between them, there's no difference in terms of what strain they're targeting. And again, we're always going to be playing catch up. So all I would say is, next year's vaccine would probably target even variants closer to it even better than they do right now. So I wouldn't be too worried about it. I think initially in the pandemic, when people were really just getting used to the vaccine, yes, there might have been, what you were saying, which is somebody might have gone some other part of the world, gotten a different vaccine, and then come here. And we all saw that happen in our clinics where somebody moved or they got one dose of an X vaccine in country and then move here. But at this point, I would say at least here, the three vaccines that we have available, they're all targeting the same strains of the COVID-19 virus, which is the most recent strains available.
Awesome. I'm going to ask you one last question before we go to the questions that are coming through our website and through Facebook. And that's how do you know when you have to be vaccinated? There are people who say, I already have my booster, so I don't need it. And when we ask them, they are telling us that it's 8 months ago. And there are people who are coming to us and say, I vaccinated myself a month ago. I'm looking for a booster. So when people have to be vaccinated?
Yes. I think what the current guidelines are for the most recent vaccines that are out there, the ones that came out this fall. I would say if you are someone who was previously vaccinated in prior years, but have not received a vaccine this year since fall, which is when the new current vaccine came out, you probably are due for one. So if you've not received a booster since fall, check in with your provider. Chances are you probably need one. If you're someone who has never been vaccinated ever and are just coming in now, then yes, you definitely could use a vaccine, and they can talk to you about the current boosters as your initial source of vaccination. And then to your question about does somebody who just got the current vaccine need another booster? It's nuanced. There are some situations, some high-risk situations where that might be true. I would say talk to your provider so that they can review your individual health situation to determine whether you need a second booster or not. What I can tell you is for the average person who is at average risk, you don't need more than one at present. So if you've gotten a booster this season, I got my booster, for example, in September, I'm good for now. I don't need another booster. But if you're someone that's at higher risk, maybe you do. So talk to your provider to find out more.
And that is really important. There are people who are in higher risks than others, particularly those who have some immunodeficiency. So those people have to be in direct contact with their providers to see when they do need the vaccines. That is really important. And we do have some questions here from people. Valeria is asking if you can tell her what it is the best brand or company for the vaccine now.
There truly is no best brand or company for a vaccine. And I'm not just saying that, it is true because you can choose whichever vaccine you feel most comfortable with. Unless you happen to be someone that had a true allergic reaction to a component of one of these vaccines, you can go with any of them. So it's not a question of the best brand or the best company at this stage. They all work. They will all do a good job of doing what they're supposed to do, which is prevent you from getting serious illness. None of these vaccines are, telling you that if you get this vaccine, you will never get COVID again. All they're telling you is if you get it, the likelihood that you get COVID and you become so sick that you end up in a hospital is low, and all of them do a good job. So I would say I would not split hairs over it. You can go with whichever one is your favorite. It doesn't matter.
That's great. Some friend of us told us that she used to have the Pfizer. This time she took the Moderna, and she had the worst reaction ever.
I've heard the same in the reverse direction too. So,
Right.
right. So it is okay to mix and match vaccines since you brought that up. That is fine.
Right.
If you are someone that got, like I can tell you personally, my initial series were all Moderna because that's what was available to me then. I believe my booster this year was Pfizer because that's what was available, and that's okay to do. You can mix and match them. But if you prefer just sticking with one because you had a good experience with it, that is totally fine too. There's no need to change it around.
Perfect. Next question comes from Sophia, and she asked if, by any chance, do you know if the COVID symptoms change after getting vaccinated? So,
It's a good question. So what I would say is not so much that symptoms change, but the intensity of your symptoms can. So people that are vaccinated can often have milder symptoms or no symptoms compared to people that may be unvaccinated. And so that's important to keep in mind because I'm starting to see a lot of people right now forgetting that what they're having could be COVID because it just feels like, runny nose, something, I don't know, doesn't feel too bad. I got the vaccine. It could still be COVID. It's just likely that because you were vaccinated, you have very mild to no symptoms from it. So not that the symptoms itself have changed as much as the intensity.
awesome. Wonderful. Now, Guille is asking us if do you know if by any chance the new variant affect children more than any other people, and if it is even more contagious than previous variants.
So in general, as we progress through from one variant to the other, each variant gets better at evading our immunity at that point. So in that sense, it might be more contagious than the previous variant because the previous variant will be blocked by the vaccine. New variant can move forward despite that, right? So in that sense, yes. Affecting children more, I don't think I would say affecting children more, but what we are seeing is right now children are having a lot, as with adults, are having a lot of upper respiratory infections in general. Some of that is COVID. A lot of it can be other things too. Flu and RSV are just two other things. There's also so many other viruses out there that can cause upper respiratory infections, particularly in children. So I wouldn't necessarily say it's affecting children more. It is true that a lot of kids this year are having a lot of upper respiratory stuff. Some of that is also because a lot of these kids over the last 2 or 3 years have had very little interaction with other kids because of the levels of social distancing that were in place in prior years. And so they may have never had a chance to develop an immunity to some of the common respiratory infections that go around. So that's probably why we're seeing them get more of it too, but not necessarily a COVID thing.
Right. And by all means, we better take care of everyone, not focusing on one specific group only, but
Yes.
yeah, with more care, some others. So Hugo is asking you if could he be vaccinated against flu and COVID at the same time?
Absolutely. You can definitely get both of those at the same time. I got both of mine at the same time. I find it a lot easier to just get done with it. But if you're someone who doesn't want to get them together, that's fine, but there's no reason that you cannot get them at the same time.
Excellent. Yes, I also took both at the same time, and I can tell you I was really bad next day, but I feel good now. So, Danny, and this is the last question we do have here on this. Satkiel, you might find someone else asking. Danny is asking if the updated vaccine is safe for pregnant women.
The Novavax vaccine is fine for for pregnant women as well. I don't believe there's any difference in terms of its usage in that population.
Then, not recently, but in the middle of the pandemic, I read an article saying that even the vaccine might help the baby formation with some effects, positive effects against the COVID. So is that true?
So yes, and you know, this is very normal. The way our bodies transfer a lot of our immunity is to what we call passive immunity, which means the mother already has circulating antibodies to a certain infection. Some of that can cross the placenta, go into the baby. And that's very important because some of that goes through the placenta, some of it also goes through breast milk. It's important because that protects the baby in the first few months of life. Remember, right now, there's no COVID vaccine that you can get before 6 months. 6 months is the youngest age that you can think of even getting a COVID vaccine. And so in that 6 months, what protects the baby is whatever antibodies might have already transferred from the mother. And so it's important when you're pregnant to get the COVID vaccine for that reason too, because you're protecting the baby for those initial few months when they really cannot get a vaccine yet.
That's awesome. And just to close, and before asking you to tell the last words to people, I don't see any more questions. That's why I'm doing this. But I'll say it's really important to stay informed for us to make, as doctor said, very, very well, making the decisions very well informed. But also, it is important to learn that beyond the effects of the COVID, we are being confused with the fact that today the vaccine is not directly provided by the government free, but now there is kind of a process in which providers are buying the vaccines, but they are still able to provide some doses free because the government's still covering one way or another. Can you tell us about that?
So when the vaccines first came out, the government pretty much was the one doing everything, right? They were the ones buying the vaccine, distributing the vaccine to you.
Right.
They were the ones paying for it, so no one ever had to think even about cost of a vaccine because they knew it was covered. At this point, that is not true. So these vaccines are no longer available purely through that mechanism. That's not to say the government doesn't provide it. It's just that it's not the only provider, and it's a much smaller provider now than what it was before. You will find that most insurers, if you have insurance, will cover the vaccine. That's so if you have a health insurance, you should probably be fine getting the vaccine because they will pay for it. If you're someone who is uninsured and are not sure about that, there are countless community organizations that can connect you with different places where you can get the vaccine despite that. A lot of local governments make the vaccine available to people in their cities and towns. The state might make some vaccines available. And again, a lot of these community-based organizations make it available. I mean, I work at a federally qualified health center. So if you don't have any insurance, we will still see you. We will still give you the services you need because indirectly the government is paying for it because, you know, that's how we get funded. So I would say if you are in a situation where you want to get the vaccine, but you feel unsure about whether or not it will get covered, reach out to a trusted community organization. Chances are quite high that you will be able to get the vaccine without any cost to you, even without it being a government run thing right now.
That is really important. So no matter what, if you are not insured, you have the right to receive the vaccine, and you can find the ways to have it. Even we are here, HISPANIC, to help you out.
I was just about to say, I'm sure you know of resources in your community. I'm sure that will connect with them and get them a vaccine without any cost if they don't have insurance.
There you go. That is really helpful. Well, I don't see any other questions, and I guess we are to the point in which anything else you want to add to tell the people about COVID and the vaccines, because it's really important that we continue taking care of us. I mean, we do have a very low rate of 14% of the people being vaccinated, with the largest number or percentage among the elder people. But still, we need to work in vaccinating ourselves and children. So, our children, what can you tell people to close?
So yeah, I would say in my closing sort of remarks, what I would remind people is, one, COVID-19 infections are still happening around you. COVID-19 is still getting people sick enough to land in a hospital. It is still causing death. So that all that is still true. It may not be as dramatic as what it was at the start of the pandemic, but that doesn't mean it's gone. So we should never forget that it's still there. And so if you have symptoms, get yourself tested, because you don't know whether it's COVID or something else. If it is COVID, and even if you're not vaccinated, you might qualify for treatment or other things based on that. In terms of the vaccination, I would say at this point, you have to make a decision for yourself whether to get the vaccine or not, but you should use the support of your healthcare providers, your community partner, to decide on that with the right information. I don't want anyone to feel like they're being forced to get a vaccine, but at the same time, I want them to make sure that if they choose not to get the vaccine, that they're doing so with all the right information available to them. In particular, if you're elderly, over 65, or if you are someone that has a high-risk health condition, there's a very long list of what that looks like, but to name a few: diabetes, cancer, heart disease, HIV. If you're pregnant, these are some situations where I think the risk calculus is different. You probably want to be more likely to get the vaccine so that you don't end up in that situation. If you're someone who is young, healthy, has no other health issues, and you are choosing not to get the vaccine, I'm okay with that, as long as you have understood what the risks are and you're making an informed choice for yourself, with also considering all the available options for vaccines out there again, which I think is important. So now more than ever, if you're someone who does not like the mRNA vaccines, remember there is an alternative to that, and you can get that. So yeah, my closing remark would just be that, COVID-19 is still here. It's still doing what it was doing before. We have a lot more vaccines out there that are available. So talk to your provider and make an informed choice for yourself.
There you go. Don't forget it. Just pay attention to that advice, because yes, it's really important to be well informed. And also, just remember that HISPANIC is here promoting vaccination events. Follow us in our social media and our website, and ask if you have any questions. But yes, it's really important to be well protected, and better if we do that with the right information. Dr. Chandrasekhar, thank you so much. It's been really a pleasure listening to you and learning more about what is going on today. And I really appreciate that you were willing to talk to us about this. And we are going to be looking to collaborate more with primary health in the future.
Thank you. Thank you so much, Rodolfo, for having me here. And yes, I'm always happy to collaborate in any way on Primary's behalf to help you and your communities.
Thanks so much.
Have a good evening.
Bueno, amigas y amigos, todos, hasta la próxima de InfoHACER. Estén atentos y no dejen de prestar atención a las palabras del doctor. Es importante que se cuiden y que nos cuidemos todos. Muchísimas gracias. Thank you so much.